I know in the program it says I'm talking about arthritis in the hand and wrist, but with the time given, I don't have time to talk about the wrist, so I know I've already failed slide one. But this is my background. I've been with the group for about 7 years. I am a board-certified orthopedic surgeon. I also held the subspecialty certificate in surgery of the hand. My hand fellowship, as Dr. Oliver mentioned, is from Brown and Rhode Island Hospital. My residency was at Penn and MD from Tufts, and actually my BA is in political science from University of Chicago. I'm going to talk about arthritis, which literally means inflamed joints. So these are different types of arthritis that you can see in the hand itself. If any of you guys have seen me talk before, I talk fast. I try to throw a lot of information in there, so bear with me. But hopefully at the end of this, you've learned something and you find it as interesting as I do. All right, so types of arthritis. What I'm going to talk about is inflammatory types of arthritis as well as degenerative arthritis. So inflammatory arthritis, there's a lot more than are mentioned here, but I'm going to kind of focus on these and then finish up with the degenerative arthritis, which is really the bulk of my practice. With rheumatoid arthritis, 1% of the population is affected. This is an autoimmune disorder that's T-cell driven. And this problem isn't really a bone or joint problem. It's actually a soft tissue problem where the soft tissue is actually attacking the joint itself. So this is that chronic systemic erosive synovitis where the soft tissues are actually destroying the joint. Locations for this in the hand or in the wrist. Mostly you see it in the big knuckle joints as well as in the PIP joints or the kind of middle knuckles and the fingers. So criteria for a diagnosis of rheumatoid arthritis is you have to have at least 4 of these following criteria. So stiffness that lasts in the hands, or different joints for more than an hour in the morning, swelling or joint effusion in at least 3 joints, one of which needs to be in the hand. The other interesting with rheumatoid arthritis is it's very symmetric. So it's going to affect both hands or both feet. You can also develop nodules at pressure points such as your heels or in your elbows. And on lab values, you'll see an elevated rheumatoid factor. And then finally, X-ray evidence of kind of degenerative changes within those joints. So in terms of deformities, you can see here this kind of inflammation within this is called the 4th extensor dorsal compartment in the wrist, as well as up in these MCP joints. And this is really inflammation around those extensor tendons there. A lot of people come to me with this and they think it's a ganglion cyst, but it's actually inflammation and fluid around those tendons there. Some of the other soft tissue injuries that can happen with rheumatoid arthritis are ruptures. So in the thumb flexion and extension, those tendons can rupture, as well as some of the tendons that rub against the distal ulna because that becomes really prominent. And then some of the deformities, like you saw in the previous slide, is a swelling in those extensor tendon areas. The ulnar drift of the fingers, where the fingers will actually move kind of towards the pinky side. Some of the joints here will actually sublux, or actually the fingers will go more volar than they should. And a lot of this is due to the soft tissue kind of relaxing and it's not holding the joint in place. Also, the extensor tendons can subluxate ulnarly, causing some of this deformity. Now in the finger, you can develop these swan neck deformities where there's kind of hyperextension at the PIP joint and then flexion at the DIP joint. But alternatively, you can develop the opposite condition where you have flexion at the PIP joint with extension at the DIP joint. And then there's also some radial deviation at the wrist. So the wrist can actually kind of bend towards the thumb and the fingers will bend towards the pinky there. So treatments for rheumatoid arthritis usually start simply with anti-inflammatory steroids, but these disease-modifying drugs have really changed the course of rheumatoid arthritis. Rheumatoid arthritis used to be a huge part of orthopedics, and now it's not because the medications are so kind of amazing, mostly these biologic medications. If someone does need surgery for rheumatoid arthritis, especially in the hand, it usually involves the big knuckle joints, so the MCP joints. And these are going to be joint replacements. And they're done with these kind of rubber knuckles here that you replace. So you take the joint out and you replace it with these rubber knuckles. Other things are, synovectomies, so that swelling that you see around the tendons, contracture releases with those finger deformities, and then if the tendons do rupture, they will need to be repaired as well. So another type of inflammatory arthritis is this called hereditary hemachromatosis. So the interesting with this is that this can be confused with rheumatoid arthritis because rheumatoid arthritis usually affects those big knuckles, especially the second and third or the index and middle finger one. But if it's isolated to those and the patient has a history of hemachromatosis, this is usually what it is. And Dr. Schumacher first noticed this in a good number of hemochromatosis patients. And what you notice also is instead of being able to make a fist, because you can't flex that index and middle finger all the way down, you can't fully make that fist. And then you have this, what they call the iron salute fist, seen up here. But on x-rays, you see kind of this degeneration in the second MCP joint and the third MCP joint. Interestingly, 20% of these patients also have something called pseudogout, which I'll talk about in a few minutes. Treatment for hemochromatosis include actually bleeding patients out or phlebotomy, as well as iron chelation. But even with these treatments, it doesn't really treat the arthritis problems. And the arthritis is the usual kind of things: anti-inflammatories, rest, ice, activity modification, and then surgery as needed. Psoriatic arthritis is also pretty prevalent. This, very similarly to rheumatoid arthritis, is an autoimmune problem, and it also affects the T cells. So in the skin, or the dermatologic manifestation, it's that extra skin buildup because the T cells kind of ramp up the skin cell cycle, so it just pushes all these skin cells out to the surface. 30% of people with psoriasis will develop psoriatic arthropathy. And what's interesting is that some people who have the psoriatic arthropathy, that's their actual first presentation of having psoriasis. They don't actually have the plaques, they have the arthritis first. So the symptoms are kind of listed here, but similar to rheumatoid arthritis, there's morning stiffness, but the stiffness doesn't last over an hour. It usually resolves within about 45 minutes. You'll develop these sausage digits or dactylitis, where there's kind of swelling throughout the digit, usually centered at this middle PIP joint, but it's also asymmetric. So it's not that both hands are involved. It can be just one finger that's involved. In addition, you'll get these nail deformities where you see the pitting and the discoloration. Sometimes the nails will lift up. And this is very similar looking to a fungal infection, but this is from the psoriasis. There's really no treatment for that nail deformity either. It's always going to be there. Psoriasis itself is also associated with the plantar fasciitis, Achilles tendonitis, and sacroiliac spondylitis. So these patients with psoriasis, they'll have the skin plaques, they'll have the hand pain, but they also have ankle pain, foot pain, as well as back pain. So in terms of diagnosis and treatment, there's no test that tells you have psoriasis or psoriatic arthropathy. There's no cure for psoriasis that I know of yet, and really we're still trying to manage the symptoms from it. All the treatments for psoriasis are really the same treatments for rheumatoid arthritis. So Phil Mickelson has psoriatic arthritis. I'm sure you've seen the TV commercials, but these TNF alpha inhibitors really kind of helped him out a lot, and so he's able to continue play. In terms of the psoriatic arthritis in the hand, we do the usual things: rest, ice, anti-inflammatories, and then cortisone injections, are sometimes used, as well as surgery. Gout is seen a lot. This presentation, a lot of times these patients actually go to the emergency room. They wake up, they have a hot, swollen, red joint. They could have fever and chills. This is very often confused with infection. So, and what it is, it's a crystal deposition of the monosodium urate monohydrate crystals within the joints itself. So it causes the inflammation within the joint. On pathologic analysis, if you can take out some of that fluid, what the pathologist sees are these negative birefringent crystals under the microscope. So when you have gout, about a third of patients will develop these large tophi, which is almost this white, chalky calcification-like thing underneath the skin. And you only see this if the gout isn't maintained well. So if they're not on good medications for gout, then they can develop the tophi. But treatments for gout, again, are anti-inflammatories, cortisone, and then different methods to either decrease the amount of urate that's in the blood or a quicker way to excrete the urate. Pseudogout is also a crystal deposition disease, but it's a calcium pyrophosphate deposition disease. This presentation is very similar to gout, where you have a lot of swelling within a joint. Most patients present, after waking up with the problem. Again, it's confused a lot with septic arthritis in the wrist, but it's basically the crystals here deposit within the cartilage itself. So with pathologic analysis under microscope, what they see are the positive birefringent crystals, different than the gout, which is the negative birefringent crystals. But what I didn't notice on x-rays, here, if you can see it, there's kind of calcifications within that joint there. So we call it chondrocalcinosis. But whenever I see that, I usually just assume that the patient, because of the chondrocalcinosis, has pseudogout. The places that can be affected, of course, in the hand or the wrist, those MCP joints, and then you can also see it in the knee, hip, and shoulder. But this treatment for this is really kind of limited to anti-inflammatory and steroids. So I'm going to move on to degenerative arthritis. So in general, most people have arthritis on x-rays. It's almost like getting an MRI of someone's spine. Everyone has a problem, but not everyone has symptoms from it. So even though we see arthritis in a lot of x-rays, only up to 17% of people actually are symptomatic from that arthritis. So the causes for this are going to be genetics, wear and tear, or post-traumatic changes. So the joints commonly affected are the outer joints, the DIP or distal interphalangeal joints, the middle finger joints, the proximal interphalangeal joints or PIP joints, and then the thumb base is very common to be affected. So osteoarthritis, different than a lot of the inflammatory arthritis, isn't the soft tissues attacking the joint. This is actually a joint problem where the cartilage at the ends of the bones starts wearing down. And as the cartilage starts wearing down, you start getting the bones rubbing against each other, gets more sclerotic at the ends. It can form cysts underneath the bones, and then also forms kind of bone spurs around there. And I always think of bone spurs as the bone's response to try to heal itself from this injury. So symptoms from arthritis are as you would expect: pain in the joints, swelling, stiffness. Generally, you lose a little bit of motion. There can be weakness there, but that weakness is really because of pain, and deformity can happen as well. Treatment, rest, ice, anti-inflammatories. I'm sure you guys are sick of hearing that still, but it's something that we always start with, especially with arthritis. So rest, ice, anti-inflammatories, activity modification is a big part of arthritis management. In terms of therapy, it's really important to try to maintain as much motion and function as you can in the hands. Different modalities like paraffin baths can help relieve some of the pain from arthritis and help you function a little better. Splinting can also take some pressure off those joints as well as give you some pain relief. And cortisone injections into certain joints, not necessarily the distal joints because it's really hard to get enough effective cortisone into those small joints, but sometimes the PIP joints or the thumb-based joints you can do. And then, of course, surgery. So bumps that you see with arthritis out at these distal joints are called Hereditary nodes, and at the inner joints they're called Bouchard's nodes. And this is really just because those are the guys who thought of it first, or saw it first and named it. So with the distal interphalangeal joint arthritis, or these distal joints, everyone actually gets arthritis in these joints, and that's because the highest force in your hands go through these joints itself. But you'll see these kind of bumps here, and those are those Hereditary nodes, which are the joint swelling from the arthritis, as well as osteophyte formation that happens from the arthritis. But what you also can get from that arthritis are these little ganglion cysts that form at the joint. So these cysts are always because of the arthritis underneath. And that's just a radiographic image of the arthritis that's in there. So you can see kind of the sclerosis, the joint is really irregular, it's sclerotic, and so that's arthritis in that DIP joint. And back with the mucus cyst, so usually when you develop these cysts, you'll also notice nail deformity distal to that cyst. And the reason for that is because your nail actually starts growing from way back here. And so as your nail starts growing out, because that cyst is there, it puts pressure on it as it's trying to grow. So that's how you develop that nail deformity. Surgery at this joint mostly is the mucus cyst excisions. So if these become bothersome for patients, we can take those out. The most important thing is you also have to do an arthrotomy and go into the joint and smooth that osteophyte down. What they found is if you just try to take the cyst out, there's a very high recurrence rate. But if you take the cyst out and you can kind of debride that osteophyte underneath, then the recurrence rate is less, but it's still reported at 15%. The other thing I always caution patients as well is that the nail deformity that happens from the cyst may not recover if the cyst is gone. So that may just be a permanent problem for people. The other surgery performed at this joint is going to be the arthrodesis or fusion of that joint. So if you have severe debilitating pain in that joint and you really can't do the activities that you want to do, what we do is we actually fuse that joint. There is no joint replacement for the distal joints. It just needs more stability, and so that involves a fusion. What they found is the highest fusion rates are done with these headless screws. But even with that, it's reported to be a 10% non-union rate. So in the joint above it, the PIP joint, this can be just regular primary degenerative changes, osteoarthritis, or it can be erosive where it really kind of destroys the joint. So in x-rays, you can see just complete destruction and deformity of the PIP joint. These are the joints where you'll get those Bouchard's nodes or swelling at those joints. Treatment for this is going to be the usual rest, ice, anti-inflammatories, activity modification. And then in terms of surgery, for the index finger and the small finger, we usually do fusions or arthrodesis, and the inner joints we'll consider doing joint replacements. So arthrodesis or fusions for those border digits, usually it's the index and the small. Again, the highest fusion rate is with the headless screw, but it can be done in multiple ways. This just seemed to have the highest fusion rate as well as lowest complication rates. And the important thing is to recreate the normal cascade of your resting hand. So the index finger isn't as flexed as the small finger. In terms of arthroplasty, I still stick with a rubber knuckle. You know, it has a good survival rate, a lower complication rate. There are these other metal joint replacements available, and these are more similar to your kind of knee and hip joint replacements where they're not hinged, they're not connected, so they're considered non-constrained, but that means that they're also looser. There's a very high complication rate. This year, a study came out looking at 5-year midterm results, and they found a 20% reoperation rate. This image here is from that paper, and if that was one of my patients, I would throw up if I saw that X-ray. I mean, it's terrible. So I don't like the complications associated with that, and I feel like the silicone or the rubber knuckle works pretty well. So I stick with that. Now, the thumb-based arthritis is probably the most common arthritis problem that I see in the office. And this arthritis is where the thumb metacarpal meets up with the bone called the trapezium down here. So this is the second most common site of arthritis in the hand. The first most common site is your index finger DIP joint, but typically it's not something that usually needs surgery. But here's where most people have the pain. They consider it either that my thumb hurts, my wrist hurts, but it's, you know, depending on where they're holding, I can tell if it's arthritis there. Affects females more than males. And interestingly enough, when they did epidemiological studies, they found that actually your non-dominant hand is affected more than your dominant hand, which is interesting. If it's, you know, based on wear and tear, you would think your dominant hand has more wear and tear. But they say that the non-dominant hand is more commonly affected. But this is where I do most surgery for arthritis in the hand. The anatomy is somewhat complex, but basically the thumb base joint is a saddle joint, has 5 different articulations in that area. So where the metacarpal meets the trapezium, where the trapezium meets the trapezoid, where the trapezium meets the scaphoid, scaphoid to the trapezoid, and trapezoid to the index metacarpal. So there's a lot of different joints there. The motion in the thumb, I mean, there's flexion, extension, you know, that abduction, adduction, opposition, pinch, as well as circumduction. So there's a lot of different motion that joint's responsible for. To help stabilize that are 16 ligaments through their 8 muscles. The most important ligament they found is this kind of deep volar oblique ligament that connects the thumb metacarpal base to the index metacarpal base. So risk factors for developing arthritis in this area, first is female. A lot of it is related to increased ligamentous laxity. Jennifer Wolf at UConn was looking at the relaxin hormone and found that women who had arthritis also had higher levels of this relaxin hormone. Wear and tear is a big part of this thumb-based arthritis as well. So what they found is with repetitive use and heavy labor, the risk is increased 12-fold. And of course, post-traumatic injuries or any intra-articular fracture at that thumb base, as well as ligamentous injuries in that area. Clinical findings are pain, you know, localized to that area, pain when they're gripping or grabbing things. But I would say the most common thing is people have problems opening jars, opening up water bottles, things like that. Swelling or stiffness in the area, as well as weakness. And I think of the weakness as mostly being due to the pain more than anything else. On exam, the deformity that's there is usually prominence in that area from that joint swelling. As the disease progresses, the thumb metacarpal starts pulling in, and then the thumb starts compensating to try to get that full motion in there by hyperextending at that MCP joint. So whenever I see someone that comes in with that deformity, I know that their arthritis is pretty severe. There's usually tenderness in that area, crepitus or kind of a grinding sensation when you move that joint. And then Dr. Gelberman at WashU found the adduction stress test and extension stress test to be very sensitive to diagnose thumb arthritis. And that's kind of shown here, where you push down on the thumb, stress it that way, or you extend the thumb. In terms of the x-rays on thumb-based arthritis, we use the Eaton-Littler classification. Stage 1 is actually a normal x-ray, or if anything, it's actually distraction or widening of the joint space. And they believe that's because of the synovitis or inflammation in the soft tissues there that cause the joint to expand. Stage 2 is where you start having the joint space narrowing. There's some sclerosis at the ends and small bone spur formation. Stage 3 is when there's less joint space, more sclerosis, and larger bone spurs. And stage 4 is when you have the pan-trapezial arthritis. In terms of treatment, rest ice, anti-inflammatories, activity modification. For this arthritis, if you're a golfer, you want a wider grip on the golf club or tennis racket, larger grips on utensils or tools that you use, things like that. A different way or those helpers to open jars, things like that, to try to do some activity modification. Splints are shown here. So this is an orthoplast splint made by a hand therapist or an over-the-counter cool comfort splint. And so someone did a study looking at both of those, and they found that they're equally effective. They both give pain relief. It's really patient preference on which kind you want. And then I do a lot of cortisone injections into this thumb base to give some pain relief and buy them some time before surgery. So in terms of surgery for thumb-based arthritis, there's a lot of different ways to do it. One is actually with a fusion. I don't have the fusion shown here, but you can actually fuse the trapezial metacarpal joint. That's usually done in younger patients that are laborers. But you could just take the trapezium out. The kind of gold standard method's been done for the past 40 to 50 years is this one here, where the trapezium is excised and the FCR tendon is then taken, drilled through the thumb base metacarpal, rolled up and stuck in the trapezial space. You can also do different sling suspensions using part of the FCR tendon, the APL tendon. There's this new tightrope to try to hold that metacarpal base up. And what I do is actually a suture sling fixation. So it's similar to these slings, but it uses a suture here. And I don't know if you can tell this. The thumb is actually out this way. The wrist is up there. This space is where the trapezium was. But basically, there's a suture here, and it's a heavy fiber wire that I use. And basically, I do a figure of 8 through the distal FCR tendon and to the APL insertion at the base of the metacarpal. And what that does, it just slings that metacarpal base up so that when the trapezium is taken out, it holds that space so that scar tissue can fill in there to work as a kind of a buffer between those two bones there. There are different types of arthroplasty or actual joint replacements where you can put something in there that people have tried. It seems like a really sexy thing to do, but the complication rate is crazy high. So for me, it doesn't make sense to do any of those. Especially the Cochrane database did a systematic review of all different types of surgeries for the thumb base, and they found no difference in any of the surgeries. So I think the simpler, the better. So in summary, there's a lot of different types of arthritis that can affect the hand. Your diagnosis is based like anything else on your history, exam, x-ray finding. Treatment begins conservatively, rest, ice, anti-inflammatories, activity modification, and then your surgical options for most joints are the same, either a fusion or arthroplasty. So my fall and winter PSAs: be careful carving the turkey, be careful cutting wood for the winter, and keep your hands out of the snowblower. Thanks. And,